So, in this conversation, we're going to talk about the medication therapies for inflammatory bowel disease. And what can be challenging about inflammatory bowel disease is that every single patient is fairly unique in terms of the severity of their disease, the location. Do they have Crohn's, ulcerative colitis? Do they have multiple other risk factors, other inflammatory diseases? Rheumatologic type diseases. So there's so much that goes into considering medication that by no means do I expect you to be an expert in treating inflammatory bowel disease, but there is somewhat of a stepwise approach to these patients, and also there's some very important drug classes to understand because we certainly know that inflammatory bowel disease is one of the inflammatory syndromes, diseases, and so some of these medications cross over into other non-gastrointestinal areas such as rheumatology. So you'll see these drugs used across the board for inflammatory diseases. So again, I'm not trying to really teach you the management per se of inflammatory bowel disease in this particular course. That will come in later courses. But what I am trying to do is you have to have just a basic understanding of what we're talking about with these disease states. And of course, ulcerative colitis is one of the two inflammatory bowel diseases, the other one being Crohn's disease. Ulcerative colitis, we say, is limited to the large intestine. And Crohn's disease can be from the mouth to the anus. And these are inflammatory bowel diseases, meaning the bowel is inflamed. It is generally somebody who has bloody diarrhea, fairly common. It can be at worse, cases 30, 40 times a day. Patients are having bloody stool. They can come in, anemic and really, really ill. Yes, patients die from these diseases, but with the advent of several new medication classes, we are able to keep the majority of patients what we hope to be, even if they do have severe disease, that we can get them into remission. So we're not curing the disease. Curing the disease would be cutting out, if you will, surgically removing that portion, let's say, of the colon or the small bowel that's affected if it's a fairly small area. Otherwise, what we're trying to do, because we can't just remove huge portions of the bowel without issue, that causes its own set of issues. What we're trying to do is induce remission with these medications. Sometimes patients are on 1 or 2 or 3 medications. Most likely, patients with ulcerative colitis and Crohn's disease that are in more of the moderate to severe category are on several of the medications, say 3 to 4. And then when somebody flares, we add more medication on top of it, higher doses of their already established meds. So it can be quite a medication-intense disease to have. Okay. So again, I'm not trying to do an entire lecture on ulcerative colitis and Crohn's disease, but you do have to understand the anatomy a little bit with some of these situations to be able to understand what medications might be utilized for certain patients. And with that said, with ulcerative colitis, remember I said it's essentially the large colon, the large bowel, the colon. And so it can hit on just certain areas of the colon. And depending on the area in which the colitis is noted, and yes, it can move in over time, and it can get worse and it can get better. So that's why serial colonoscopies are important. But depending on where it is, that's going to dictate what kind of medications are used. So for example, ulcerative proctitis, it refers to ulcerative colitis that is within 18 centimeters of the anal verge. It's distal to the rectosigmoid junction. What I'm saying is that's colitis that we could generally treat with things like Rowassa enemas, medications that are enemas. We can't utilize an enema in somebody who has left-sided colitis, because left-sided colitis refers to disease that extends beyond the sigmoid colon as far proximally as the splenic flexure. So obviously there's not going to be any enema that extends that far. Ulcerative proctosigmoiditis, okay, so sigmoid, that is ulcerative colitis that's limited to the rectum and the sigmoid colon, and it doesn't involve the descending colon. This is really where if you're not sure of your colon anatomy, look it up quickly on Google, because it all is important in terms of where the location of disease is. It will be equally as important when we talk about Crohn's disease, okay? And then extensive colitis is pretty much throughout the entire bowel. So first and foremost, when somebody comes in and they have a new diagnosis of inflammatory bowel disease, whether it be ulcerative colitis or Crohn's, they're generally pretty sick. You know, they're having symptoms. That's how they got diagnosed. It's pretty rare that we diagnose somebody with IBD just because they were due for a screening colonoscopy. That's just not the way it works. So these are patients that are coming in a flare, basically. And so you have to get them into either gastroenterology soon, or you have to start something for them. So induction of remission is the first step, and that's going to be with a combination of the 4 categories here, either topical or rectal mesalamine, again, depending on the location, topical or rectal glucocorticoids, oral 5-ASA derivatives, which we'll talk about, and then glucocorticoids just in general, which is a sort of a different group of the topical rectal glucocorticoids. So that's first and foremost. And then, again, I'm not going over the really severe, moderate to severe ulcerative colitis patients, because when we talk about Crohn's disease, a lot of those medications cross over to Crohn's disease, and I'll tell you which ones they are when we get there. So we hope after a period of starting medications, the ones I listed on the slide before, we hope that we can either alter the dose a little bit, maybe take away 1 or 2 of the medications, and keep them what we call in maintenance, and maintenance of remission. Again, not cure, but just maintenance of disease. And that would be with topical and rectal mesalamine, again, depending on disease location, as well as the 5-ASA derivatives. And we'll go through those now. So one of the medications that you might see is topical or rectal mesalamine. When it comes in a suppository or retention enema form, it's either Canasa as the suppository, which is 1 gram, or 1 suppository once or twice daily. When we see it in the retention enema form, it's Roasa enemas, 4 grams or 1 60 ml unit. It comes like that, 1 or 2 times per day. And again, that's going to be for that patient with more of the proctitis type picture, where an enema would hit up upon that diseased bowel. You'll see maybe twice a day in a flare, maybe going back to once a day. A lot of times we give these nightly before bed, so that the patient can sleep without being woken up to have bowel movements. So again, that's in a pretty mild disease that we can get away with just utilizing rectal mesalamine. So some patients don't respond to mesalamine in terms of a rectal formula. So in that particular case, but let's say that they do have disease that is limited to the proctitis type region, in terms of the distal colon, then we can try rectal glucocorticoids. Rectal glucocorticoids, though, because again, they are steroids, we try to do less than 8 weeks with any of these. You have to be careful. This is a topical/rectal glucocorticoid, and you have to be careful of long-term use and adrenal insufficiency as a result. So I've listed them, but they're basically just all different variations of hydrocortisone, and they come in different preparations. I'm not going to, hold you to knowing that. I just want you to be aware that there's different hydrocortisone options for patients who can't utilize rectal mesalamine, or perhaps rectal mesalamine just wasn't effective. So one of the things I think is hard about inflammatory bowel disease, even for me teaching it, is that it's one of those disease states where you really have to just have experience with it and to kind of understand the nuances. So I think this is a good example. We know that the oral 5-SA ASA derivatives are kind of the mainstay of treatment. That's sulfasalazine and mesalamine. And you're going to see that I'm going to refer to those as being building blocks of medication for Crohn's disease as well. So inflammatory bowel disease across the board. These are sort of the mainstay for anybody who doesn't have the option of using topical agents, which is the vast majority. But there are so many drug options that it makes it a little bit challenging. So I'm just giving you the basics here. And that is, you should be seeing patients on sulfasalazine, which is azolfidine or salazoprin, about 4 grams daily in divided doses. So oftentimes it's 1 gram 4 times a day, or mesalamine, and the range can be from 2.4 to 4.8 grams per day. And there's all different formulations of mesalamine nowadays. I put etc. because there's about 5 more that I don't see as often but are actually available. So we have Asacol, Delzacol, Lialda, Pentasa, and Apriso, which I think are the major ones you'll see patients on. And what's a little bit interesting about these drugs too is that we change the doses up fairly frequently depending on how patients are reacting. And are they in that induction phase of medication, or are they in the remission phase? And sometimes it doesn't make a difference. Sometimes we can't make any changes at all, but you will see patients, having different doses coming into your office or into the hospital than the next person, or than perhaps what they had 6 months ago. And I will also say, these are several pills a day. My husband is on Delzacol. His pill bottle is massive because it is 4.8 grams per day. That's, I think it's 4 pills 4 times a day. So this is fairly unlike what we do in most other disease states where patients take a pill a day. He has moderate ulcerative colitis and takes Delzacol as his main medication and then is on Humira, but just the Delzacol alone is, I think, 16 pills a day. So it's not easy for patients because they're like, wait, did I take it 4 hours ago? I'm due again. But this is what we have, right? It's the bowel, so we've got to have drugs that are sitting there working pretty consistently. It's just how the bowel operates. I didn't really do a lecture on antidiarrheal medications because I feel like you can read some of that in the textbook. It's fairly straightforward. But, and in addition, I do have a lecture that's posted of just some basic GI medications. But truth be told, patients can't just utilize most of the time the medications that are posted for treatment of Crohn's and ulcerative colitis. They also need antidiarrheals. And loperamide tends to be something that is used fairly commonly, as well as cholestyramine. Cholestyramine we also use before meals and bedtime for patients who have had their gallbladders out and who have a lack of CCK because of the gallbladder removal. Yes, a lot of patients do, after having their gallbladder removed, have a diarrheal syndrome that requires cholestyramine at least for some period of time, if not long term. So then not only do we have the glucocorticoid topical rectal type option, but obviously those patients who have more systemic or shall I say left-sided colitis, as well as those with Crohn's, require an oral or IV glucocorticoid option. So we have some different options. Budesonide is a delayed and extended release corticoid and it's 9 milligrams each in the morning for 8 weeks. Patients will, one thing you need to know, patients will, with UC and Crohn's, when they have flares, the doses of steroids are much higher and much longer duration than, say, somebody who is utilizing a steroid for, I don't know, maybe pneumonia, or COPD type exacerbation. So when you see 8 weeks, absolutely, it's 8 weeks, and then the tapers start, and they're very long tapers, very slow and very long tapers compared to prednisone tapers anywhere else in the body. So these are patients who have a tough time even coming off of steroids a lot of times. Steroids were one of the mainstays of treatment until some of the medications that we're going to talk about under the Crohn's disease slides came into play. So you can imagine all the adrenal issues and all the endocrine type concerns, and then when you start to think about brittle bones and all the types of things that go into being on long-term high-dose steroids, this patient population of inflammatory bowel disease patients really struggled with that until some of these newer drugs came out. So I'll leave that for you to look at. So basically the mesalamines, the sulfasalazines, both oral, rectal, the steroids as needed for flares, kind of what we think about in fairly standard cases of ulcerative colitis and maybe even some real mild cases of Crohn's. But in our patients who have more extensive ulcerative colitis, more severe disease, as well as more severe Crohn's disease, there's a whole nother list of medications. And I'm kind of saying Crohn's disease here, but it should say, Crohn's disease and more severe ulcerative colitis. And there's a whole list of different options that we now have available for patients. And so, again, I just want to go over them in a fairly simple approach. But just, I think you should have some understanding of these drugs because they're not just, a lot of times, like the anti-TNF agents are not just used for Crohn's disease and ulcerative colitis. They're used for RA, rheumatoid arthritis, and psoriatic arthritis, and things like that. So you're going to see these drugs, I think, more and more, especially those biosimilars and the anti-TNFs. So what I want to say in this slide is just as a reminder that, again, patients with inflammatory bowel disease can be on several different drugs, even during remission. I think I mentioned my husband. My husband is on Dosacol every day. He's also on Humira every week. That's considered his remission status. If he were to have a flare, we'd be adding things like some of those glucocorticoids that we had just mentioned, to say the least, or changing into one of these different sort of anti-TNF or biosimilar type agents. Now, I don't mean to use my husband as the poor example here, but I mean, even in somebody who is well managed and stable, there's several, different points in his life where he's had multiple different medications, and at best, he's on 2 right now. So combination therapy is oftentimes, for especially Crohn's disease, a biologic agent like a TNF inhibitor in combination with immunomodulators. So for the Crohn's patients, they don't necessarily start with the mesalamines as much as they start with azithromycin or AZA and 6-mercaptopurine 6-MP. I'm not asking you to be proficient in doling out these medications. You shouldn't be. But you are going to see a lot of patients over your career on these meds, and they get confusing. So with those medications, the idea is that, there's a low starting dose, but it can get pretty high in terms of 2.5 mg per kg per day. So you can have a wide range of medication in terms of dose. The other thing is you have to monitor LFTs and CBCs and electrolytes, to be honest, fairly regularly with all of these medications coming up. So I'm really going to talk for just a minute really about Remicade and Humira because Sotolizumab Pegol is third line. We don't use it that often. But Infliximab, which is Remicade, and Humira, these are mainstays. I know you see Humira commercials on TV for multiple different inflammatory situations. So let me just tell you what they both are. So Remicade, which is listed, is a chimeric IgG1 monoclonal antibody against tumor necrosis factor alpha. And it's kind of an interesting medication. It's 75% human and 25% murine sequences. So it has a high specificity for and affinity to tumor necrosis factor alpha. So that's what we're going after in treating inflammatory bowel disease. Generally, we hope that patients will go into remission around 12 weeks. These are Remicade is an infusion that is given, and it goes at different sequences. So it can be every 2 weeks for a certain small period of time, and then it goes every 4 weeks, and then if they go into remission, it can be every 8 weeks. Humira is a recombinant human IgG1 monoclonal antibody, again directed against tumor necrosis factor alpha, and that's a subcutaneous injection. So when Humira came out, it was a godsend because people didn't have to take 2 to 4 hours out of their morning every month or couple weeks to come into an office setting and do an infusion, get an IV and get an infusion. So Humira is given, for example, it's generally given weekly, and it's just a sub-Q. What people used to complain about with Humira is that it burned. It was very painful, which I can attest to watching my spouse. They have reformulated it, and now it's much less painful for patients. So these are mainstays of treatment to try to get people into remission with either moderate to severe ulcerative colitis or Crohn's disease in general. And again, as mentioned, you do have to check labs with these medications because they are all medications, all these ones listed, that can affect liver function tests. They can affect the immune system as well, right? So these are patients who also should be on up to date on all vaccinations and the like, okay? So I should have mentioned two things to you, and I'm just realizing it. One, biosimilars I'm not talking about because biosimilars aren't really quite available yet. But if you were to take those anti-TNF agents of Remicade and Humira and you were to sort of enhance them, that's what they're working on in the biosimilar area. Something I should have also mentioned in the last slide is simply that we use Humira for ulcerative colitis, potentially also Crohn's, but we really reserve Remicade more for Crohn's patients, generally speaking. You don't need to know that. It's just, just for your own understanding. We have a new class of medications, though, for patients who don't respond to those anti-TNF agents. So if somebody fails Humira and Remicade, especially the Crohn's disease patient, they can utilize a drug called Stelara, which is an anti-IL-12 and 23 antibody. Basically what it does is it blocks the biologic activity of IL-12 and IL-23, and that inhibits receptors on those cytokines, on the T cells, as well as the natural killer cells and antigen-presenting cells. Entyvio is a humanized anti-alpha 4 beta 7 integrin monoclonal antibody. Whew. Surprised I remember that at this point. The induction dose is about 300 milligrams IV at weeks 0, 2, and 6 for maintenance, and then it's like every 8 weeks thereafter. So it's similar to the anti-TNF agents, where you're building up, from an induction dose to a maintenance dose. And again, these are injections. Tysarbi is also a medication in this class. I kept it here, but it's also like Entyvio being It's a humanized monoclonal antibody directed against alpha 4 integrin. It blocks leukocyte migration to the sites of inflammation, if you really want to know. And it's limited because it's associated with some serious adverse effects like progressive multifocal leukoencephalopathy, PML. So I'm not really seeing it in use, but in case you hear of it or see it in textbooks. So always remember too the glucocorticoids that I mentioned in ulcerative colitis would hold true for any flare for Crohn's disease. And the take-home message here is there's a stepwise approach for gastroenterology to manage these patients. You're going to see patients coming into the hospital not being able to stay on these medications because we don't have them in hospitals. So you're going to be putting them on something as simple as mesalamine and prednisone or solumedrol. You're going to see them in your offices because they're going to come back from gastroenterology, and you're going to have some understanding of what these drugs do. So that's why I really wanted to take time to separate out these drugs because there's so many different types, and rarely do I see somebody just taking one medication for IBD. So again, we're talking IBD, not IBS. If we're talking IBS, we'd be just treating constipation and diarrhea, and we've talked about some of those medications already. I hope this helps, and again, I don't expect you to be a GI specialist. It's just these are evolving classes of drugs that I want you to be aware of. Thanks.